Good evening, everyone. I'm Dr. Anikha Bellad, a physician scientist with an MD and PhD from Institute of Bioinformatics, Bangalore, and I'll be moderating today's session. I thank Ms. Chetana and ORDI for giving me an opportunity to moderate this important session on autism spectrum disorder. We all know over the past decade, the reported prevalence of ASDs is increasing, and it is one of the public health concern. So, to walk through this field of medical practice, we have with us today Dr. Prashant R. Utage. It's my privilege to introduce Dr. Prashant and welcome our esteemed speaker for today's session, who will be speaking on autism spectrum disorder, clinical profile, and role of early intervention. Dr. Utage is a distinguished senior pediatric neurologist and currently serving as a director and CEO of Utage Child Development Center, with centers across Hyderabad, Latur, Nanded, and Bidar. He's also a medical director of the Umang Institute of Autism and Multidisciplinary Research Center in Maharashtra and a faculty member at National Institute of the Empowerment of Persons with Intellectual Disability, Hyderabad. Dr. Prashant completed his MBBS from MMISR Medical College, Latur, Maharashtra, followed by his DNB in Pediatrics from Durgabai Deshmukh Hospital, Hyderabad, and further pursued his fellowship in Pediatric Neurology and Epilepsy from the prestigious Wadia Hospital, Mumbai. In addition to his medical training, he has enriched his experience with qualification in medical law and ethics, applied human rights, hospital administration, and law that reflects his holistic approach towards healthcare. So, Dr. Utage holds several key professional positions, including Secretary of Academic of Pediatric Neurology, Telangana, and he is an executive board member of the Association of Child Neurology, India. He's also an accomplished researcher with numerous national and international publications. His work includes innovative research on video-based real-time assessment and diagnosis of autism using deep neural networks. And also, he is involved in clinical trials targeting co-syndrome of autism spectrum disorder and extensive contribution in pediatric neurology and genetic disorder. In recognition of his significant contributions of child neurology, he was honored with the award from Association of Child Neurology for outstanding contribution in child neurology in 2023. With his vast clinical experience, academic involvement, as well as research contribution in autism and pediatric neurology, we are glad to have Dr. Prashant walk us through today's important topic, understanding the clinical profile of autism spectrum disorder and the critical role of early intervention. So please join me in warmly welcoming Dr. Prashant. Over to you, Dr. Prashant. Thank you.
Thank you, Dr. Anikha, and thank you, ORDI. This is mainly, it should be a interactive session than the theoretical one, I feel so. So just before going for that, just want to know what is our audience? Is it a medical or a genetic or it's a parent?
It's a mixed audience. So we have medical and researchers as well.
So just I'll try to be in general rather than going into detail more of a scientific. So I have to balance both. Yes, I work with the medical profession and being I am working with NGO at Maharashtra government and Telangana and Karnataka. So we work with parents also. And there is a lot of knowledge now available by social media, by Reels and Facebook. But I'll try to make it short about that and then what is the role of early intervention. So shall we start with the session? So my slides are visible.
Please go ahead. Yeah, they are visible.
So today we'll be just seeing what is autistic spectrum disorder, more of a clinical profile, and what are the early intervention, then role of genetic in a diagnosis. So there are many problems which we come across during our childhood. I think we used to face a lot of infectious problem in a kid, and now there are a digital problem. And part of it is there are like attention deficit hyperactivity disorder, there is a speech delay, there is a sensory processing disorder, there is a difficulty in learning, we call it as a dyslexia or learning disability. And the major problem what we are facing is in India is the autistic spectrum disorder. As it is a spectrum, usually parents or professionals also will search for autism. So there is a difference between complete autism and spectrum or mild spectrum disorder. So I'll go through what is introduction to the topic. Then what is the definition of autistic spectrum disorder? What are the red flags? Being a professional, we are moving around. Even we go to to our own relatives' home, we should be able to find out there are red flag signs or there or not. How do we diagnose it, and what is the early intervention? I always see now it is around 17 years I have been practicing in this area of neurodiversity or neurodevelopment. In initial 2008, 9, 10, we used to see hardly 1 to 2 cases of autistic spectrum disorder, and the number has slowly increased. Post-COVID, the number has increased significantly. Now, presently the incidence of autistic spectrum disorder, initially it was 1 in 2,000, then it has come down to 1 in 1,000, 1 in 500, 1 in 100. Still, there is no clear-cut data, but at present, the global census is showing the 1 in 36. Indian data is not much available. Actual figure may be more than that. So there are other factors also. There may be increased awareness in a professionals, increased awareness about the autism, and then there is a diagnosis. There are multiple factors for it. So it's always unique and totally interesting, sometimes mysterious. So they may be having the affection or affect in a social communication, but they may be something different or good at many of the things. Like they may be good at painting, they may be good at drawing, they may be good at IQ, that means high functioning autistic spectrum disorder. Per se, the definition of ASD, according to DSM-5 criteria, it consists of previous manuals autistic spectrum disorder, that is autism, Asperger's disorder, childhood disintegrative disorder, and pervasive developmental disorder, which are not otherwise specified. The autistic spectrum disorder is characterized by mainly there is deficit in a social communication and social interaction. Rest of the things may be normal, and there is a restricted repetitive behaviors, interests, and activities, RRBs. But I think overall, the period of time we go through the slides and videos, we will be able to know detail about this. These are the hypothetical anatomical location of the this autistic spectrum disorder. I won't go into details of the structure, but regarding genetic, as now till now, almost all 5,000 kids with autistic spectrum disorder, we have sent this genetic testing. So we come across there are many genes which are associated. They may be the presynaptic terminal, synaptic, or postsynaptic terminal. So there are many mutation which come across, which is one of the major etiology for the autistic spectrum disorder. Now, what are the 5 internationally recognized red flags for the autism? This should be known by doctors, but it is more for the in general parents or those who are the healthcare professionals. If the child is not able to babble or poo by 12 months of age, so we should be having red alert that are we dealing with autistic spectrum disorder? Does not gesture or point or wave or grasp by 12 months of the age. Means child should be reacting or giving reaction to the different stimuli. If it is absent, we need to have the red flag. Okay, are we dealing with any developmental delay, especially dealing with the autistic spectrum disorder? Does not say single word by 16 months of the age. Does not say 2-word phrases on her own. And by 24 months. So here I want to stop for a minute, and I want to clear that speaking is not only saying the word, so it should be a purposeful. Like take an example, if one child is completely replicating the rhymes like A, B, C, D, colors and rhymes, that he's not able to say, "Mommy, give me a chocolate. Mommy, I want to eat." So it is a purposeful sentence, but just saying the rhymes is not the speech. It may be just repeating the words. And if it is the 2-word phrases are absent by 24 months of age, we should be aware that are we dealing with speech delay or autistic spectrum disorder? Any loss or regression of the speech or language or a social skill. Usually, if we see in a clinical scenario, when the parents come to us, they clearly says by the 8 months child was able to give eye-to-eye contact, able to say mama or ma, pointing it out, giving the social smile, but the same child get regress, no eye-to-eye contact, absence of social smile, not responding to call by name by the around 1.5 year. So this is a typical history of regression. So what are the causes of the autism? So as I said, it is a multifactorial. So initial hypothesis was it is a genetic. So in male, it is commonly that twin Indian scenario, it is a Fragile X syndrome. If the parents' age is more, as you know, because of the career orientation, the marriages are late and the pregnancies are late. So that may be one of the reasons. Other biological and environmental factors, that is the nuclear family, lack of the people at the home, there may be a pollutant or perinatal or prenatal factors. So there are many, and there are one more thing I want to clear for the parents or professionals that, as Trump said, the utter the word vaccination causes the autism or not, but clear cut the study which since 2001 till date, there is no clear cut evidence saying that vaccination causes autism. So I have seen 2010 to 15 that every therapist or professional used to say, those who are working in a autistic spectrum disorder, that vaccine should be avoided. But at present, there is no strong evidence to support. As being a medical, we always see the what is the strong evidence. So there is evidence says that there is no evidence that vaccine causes autism. Means vaccine is not harmful or MMR vaccine association is not yet clearly proved. Other risk factors, as I said, child born to an older parent or at risk of having ASD, then first sibling having the autistic spectrum disorder, there is increased chance, 10% more chance that they have this second kid having autistic spectrum disorder or speech delay. Other genetic disorders like Down syndrome, Fragile X syndrome, tuberous sclerosis, and there are many more genetic disorders. What we used to read in a Nelson during our pediatrics or neurology in Swayman, that we are now able to see in our genetic test. The genetic test is the major contribution initially. This is a risk factor for the twin, which is around 20 to 40% more higher. Now, DSM-5 criteria, I don't go into detail, but it is autistic spectrum disorder. As I said, there are two things, mainly the social communication and interaction is affected. So 3 out of 3 should be present to call it as an autistic spectrum disorder. So what are the 3 things? So this deficit in a social emotional reciprocity. I just read it out because this is important, and then I'll go to the videos where we can see practically what I am reading. It has to be seen in a video. If there is a non-verbal communicative behavior used for social interaction, that is eye-to-eye contact, body language, and then facial expressions, and the oral language. The deficit in developing, maintaining, and understanding the social relations. Second criteria is restricted repetitive pattern of behaviors, interests, and activities. So at least must have 2 out of 4. So what are the 4? Stereotypy or repetitive motor movement, use of the object or speech. Humming also it comes under stereotypes. That is the oral or speech stereotypes. Insistence on the sameness, so they doesn't tolerate the change in their routines. Inflexible adherence to the routines or ritualized pattern of verbal and non-verbal behaviors. Highly restricted and fixed interests that are abnormal in intensity or focus. Hypo or hyperreactivity to sensory input. That means if there is a whistle of the cooker, some child may be not reacting anything, but some child may just close the ear or become more hyper with this sound. So this is a auditory hypersensitivity to that sound. So now let us move towards social communication criteria. So there is a deficit in a social emotional reciprocity. So as you know, when we entered, we try to talk to the child, there will be to and fro communication, eye to eye contact will be maintained. But in this, even you try to talk with the child, he will be completely unresponsive, no emotional interest. He doesn't notice that you are present there. So he'll be playing on himself. He may not notice that parents are coming in or leaving his least bother. he may go to anyone. So there is no differentiation or emotional attachment with the parents or their own relatives. Just try to play the video, the whatever, as I said. I think video. Let it be in further videos. I think after all criteria, I'll be able to do that. Second criteria is social communication criteria, that is deficit in a non-verbal communicative behavior used for the social interaction. What is mean by non-verbal? Means we are not speaking, but when we are speaking and there are 10 people in a room, we have to have first eye-to-eye contact. So the person opposite to us understand that, okay, Dr. Prashant is talking to me. So this is very, very important to have the social interaction. And this will be absent in this child. So poorly regulated, integrated verbal and non-verbal communication, abnormalities in the eye contact, that they may be just looking towards one side of the this one, and there is an abnormal body language and deficit in understanding the gestures. Total lack of facial expression and non-verbal communication. As I said, even you try to forcefully turn the child and look at you, child won't be able to maintain that eye-to-eye contact. He tries to avoid, you want to play with himself, no facial expression. Second thing is now third criteria is the deficit in developing, maintaining, and understanding social relation. It is like when you go to someone's home with your kid, so he won't be able to interact with the peer group. There are many kids, but he will be separated for them with himself, unable to start the conversation or imaginative play. And there is absence of the interest in the peers, means he won't be able to interact with his peer crowd. Now, repetitive restrictive behaviors, as I said, there are around more than 25,000 kids with ASD I have seen. So all these patterns, what has been demonstrated into the figure, it's more than that we have seen. So typically lining up the toys or a cars or his color box in the particular pattern, there may be a hand clapping, there may be a biting, flickering of the fingers, there may be a rocking, there may be echolalia. Now, as I said, echolalia always get confused with the speech. That means parents, in their initial reaction will be rejection. Because if you see, typically this child will say rhymes, ABCD, colors, numbers. But they won't be able to tell Mama, I want the food. Mama, I want chocolate. Papa, take me out, but they will be telling the rhymes. So parents get confused that my child is completely clever. He understands everything, but he says the rhyme, but he only don't talk in to and fro conversation. So it's representing the echolalia or some phrases they understand through their digital media. Now, second one is the insistence on the sameness and inflexible adherence to the routines. So it's their fixed pattern. If you change that pattern, they will throw the tantrums. They will have the small changes. To give the example, usually when mother come to our therapy center by their own car, but one day their car broke down and they have to come by the taxi. But by seeing change in the car, child started throwing the tantrums. Second thing, usually he has to go to one shop, pick up the toy and come. It was a daily routine. But they didn't stop at that shop, they start showing the tantrum. So their thinking pattern is rigid. They cannot tolerate a little change. Now, repeated restrictive behavior criteria. So they are like, if someone likes the dinosaur, wherever they go, either it is mall or someone's home, they will try to go towards that particular, like Mario. So they will be finding out only that Lego Mario's picture. If they are fond of car, wherever they go, they collect the more car. So it is excessive interest and emotionally attached with them. Now, fourth one is the hyper and hypersensitivity to either visual stimulus, either auditory, either they have this gustatory or the oral stimulus or touch. So they have very difficulty in having the haircut. There may be, if you see such child, they may have the self-biting behavior or biting to the others. and many more. Some kids, if you see, they try to smell each and everything, which looks very odd for the parents. Some kids they go to the other's home and they look towards the rotating fan. So he has the visual repetitive behavior. Now this video I'm demonstrating it. This is a very severe autistic spectrum disorder. If you see the child, there is a oral continuous humming sound, very restless, agitated. He is moving in a particular fixed pattern, going to and fro. This was the day one of the therapy. Child was not at all cooperative, not responding to the call by name, no eye-to-eye contact, and severely hyper. Same things we'll see after going through the intervention. So here, child therapist is trying to get the eye-to-eye contact, but he is unable to maintain it, not responding to call by name. Here also one more therapist trying to get the attention of the child, but he's not at all bothered. He's not aware that someone is sitting around. He's looking towards the bright colors, object and toys. One more child. What is your name? Look here. Look here. Look here. I'm trying to get his attention, but he's not able to. It's a little bit well-grown child. So these are the typical red flags or the clinical picture of the autistic spectrum disorder. So someone may have mild, someone may have the moderate. Now to screen them, there are like 18 months, 24 months, and 30 months. There is a MCHAT score and there is a revised MCHAT. So that has to be done at 16 to 30 month age. And this chart is available in 21 languages and very easily freely available. There are 20 yes or no items, which if you give to the parents, then you will come to know. If the score is less than 3, you need not to do anything, but we need to have the alert and try to give the more stimulation. If the score is 3 to 7, don't wait for assessment, just start the stimulation. Score more than it, definitely we need to start the speech stimulation, therapy stimulation, along with that simultaneous assessment. Now, while evaluating, we have to go into details, antenatal history, natal birth history, postnatal, how was his developmental milestones, if there is any regression, social emotional development has to be seen, physical examination for any signs of dysmorphism indicating towards any particular genetic syndrome like Down syndrome, Fragile X, or the Edwards. Behavior observation of the child, we have to see the eye-to-eye contact, joint attention, social reciprocity, communicative intent, and pointing the gestures, play, use of the toys. What are the comorbid condition? Now, why I'm insisting on this comorbid condition? Because there is always a condition confusion that parents go through the Google and they say there is no treatment for autism. But if the child is having autistic spectrum disorder, along with that ADHD, anxiety, depression, intellectual disability, sleep disturbances, then it has to be treated with medication. So we need to screen for these are the enlisted entities of the comorbidity. Now, genetic testing, everyone is aware that there is a chromosomal microarray, simple karyotyping. In Indian scenario, if the child is male having autism features, we need to think that this could be a Fragile X syndrome. Till now, we have sent around more than 100 samples, but I have not seen a single child with Fragile X positive in India, in my own patient. And there are other many more genetic testing like chromosomal like whole exome sequencing, whole genomic sequencing, and there are toxicity profile, many more, but we won't go into details of that. Now, now this is the called as autistic spectrum disorder. Now, what mean by the early intervention? So, early intervention is defined as introduction of the plan programming, deliberately time and arrange in order to alter the anticipated or projected course of development. Means if you screen the autistic spectrum early, you have to start the therapies early. That means it is an early intervention. So that projected autistic spectrum disorder or moving towards the severe autism, you can halt it or you can anticipate them and you can avoid. So what is the rationale for red flags and early intervention? So main rationale behind a red flag and early intervention is that earlier learning is the foundation for the later learning, which is one of the principle of child development. Most of the brain growth, neuronal plasticity, sensory motor development, learning, language development, and cognitive development will and personality trait and social development is achieved in first 2 years of life. Now the question is the only thing that completely the growth will stop by 2 years? No. It will be going on throughout the age, but the speed of the growth will be more in first 2 years of the age. So, what are the objective or main objective of or early intervention? So, by early intervention, by starting early intervention, we can prevent the developmental delay and disability, screening and identification of the at-risk children, stimulating the child through the normal developmental channels, enhance the normal development and independent functioning of the child, maximize the residual capacity, minimize the need for the therapy in the future and special education, and increasing the family awareness, involvement in the intervention that will emotionally bond the child and mother together. And ultimately, if we start early intervention, it is going to bring down the financial burden and emotional burden of the family and ultimately the rehabilitation services of the country. So brain development is mainly the activity dependent. If you do the activity again and again, so that wires will get strong. If you doesn't use that wires during first years, they will get pruned and they go disappear. So that is the main principle. So most complex, the human brain is very complex organ having 100 billion neurons at birth, and for one task at a minute, there will be 2.5 lakhs to 5 lakh neurons will be working per minute. So the neurons which fires together, wires together. Example, if you teach the child reading the book in early childhood, they will pick up and they will be more interested. At the same time, if you give the mobile to the child, he will be having only capacity of observing and listening to the that doesn't respond to the human stimuli. Why? Because the neuron that fires with the digital sound and the colorful environment, it will fire together, wire together. So they excite the neurons which are actually not required at that time. And lack of human interaction, maybe because of the nuclear family and excessive use of gadget or screen exposure. There is a correlation because it is more firing, more wiring into that. And that's where there is a regression has been seen into this. So I won't go into details of brain growth, but it is, we can say it is mostly 80% during the first 2 years of the age, but throughout the year, throughout the life, there will be a changes in a neuron. It is not restricted, but speed will be reduced after that. So these are the connections which are important for different action. And if there is a more stimulus, there will be a more synaptic synaptogenesis, neuroplasticity, and that will increase the with the more stimulation. This is just to give the example. This is a synapses at birth, and this is at 2 years. The same child, if you don't stimulate this, branching won't be there. And what are the kids who are at risk? So these are the preterm baby, an active graduate, multiple like twin pregnancy, any infection or intraventricular hemorrhage during the neonatal period, child on a ventilator, and many more, dysmorphic child, hypoglycemia and hyperglycemia. So what is now this? So this is the importance of early intervention. Now, what is the team required for the treatment of autistic spectrum disorder? So basic pillar is the pediatrician, developmental pediatrician, and pediatric neurologist. But once you pick this up, you need a complete team of rehabilitation, that is child psychologists, psychiatrists, then your audiologist, speech therapist, occupational therapist, genetic consultant, and the social worker and the dietitian too. So it is, if it is a cerebral palsy, then obviously the pediatric orthopedic surgeon is also a part of this team. See, it is not a single job of a single person, so it is completely team which is required for this. So these are the child with the hypoxic damage, hypoglycemia was there, and these are the therapies which are working on a different stimulations. So the same child, what I was talking about, we'll see the video of the same child. So energy was very high. Child was not at all able to sit at one place. Restlessness was very, very uncooperative during initial days of the therapy. We call it as a severe hyperactivity. And his grade of autistic spectrum disorder, like CAR score was very high. So this video we have seen. Now the same child, if you see, so with the intervention of the same child, the energy levels has decreased. Now child is in same child now responding to the therapist, doing the purposeful activity, responding to call by name, following the commands, following the sitting organs has also improved. Now this is one child. Now this is the second child. So this video we have seen. Now we'll move from now child is aware of the activity. Now holding the object. Now child is able to follow the commands. Attention span improved. Same child, same therapist. After some few couple of months of the therapy. So this is a kind of early intervention. So being a team leader, we have diagnosed screen it early. Class 4 was mild to moderate ASD. Child was not responding to call by name, no eye to eye contact. But the same child, if you see, after early intervention, child improved a lot doing the purposeful activity. So one more child's video. So child want to escape out of the therapy room, was not at all concentrating on therapy, continuously crying. So this is the therapy started, but at that time it's poor sitting tolerance. Now same child, if you see, after a couple of months of therapy, this is the sensory integration, what they are doing with. Now child is able to cooperate, no crying, no screaming, sitting tolerance has increased, cooperative to the all therapies. So this is the power of the early intervention. And these are the basic services when I started my practice in initial days of the my practice was now also it is morely concentrated on metro cities, but I tried to replicate here in a like peripheries like Latur, Nanded, and Bidar. So I stop here. I won't go into details of medical management, but if anyone to talk on that or anyone want to know about the new medication that is leucovorin has been launched and the complete world is talking on the leucovorin and practice, so we can discuss further. Thank you.
Thank you, sir, for an extensive talk and giving us the overview of ASDs and the early, how important is the early intervention and other things. So I would request all the participants to put their questions in Q&A. So we currently do not have, so I have a couple of questions to you, sir, so that we can wait for the audience to come up with their questions. So considering ASD as a like a wide spectrum of disorder, how do you what do you think about if they are subtle, and what are the early signs which a pediatrician would have to pick up when they are subtle or the borderline cases?
So pediatrician are the like
Mm.
major pillar who come across the child vaccination from day one. So they are the one who knows the normal developmental milestones. If any little bit deviation from that, usually initial days there was less awareness and less talk about the autism, but now every conferences there are separate conferences on the autism and neurodevelopmental disorder. So for early childhood development. So now everyone is aware of that. Only thing what we read or what we see on a lecture, we have to just keep eyes and mind open. What your mind knows, your eyes will see.
Yes. So most of these people end up with the primary physicians or the pediatricians at the first place. So what are the screening strategy a public should at the primary healthcare center?
See, MChat, that is the, if you give the developmental chart and their deviations simply to the parents, it's usually printed on the backside of the file
Yeah.
of every pediatrician.
Okay.
So that will alert them if
Yeah.
there is a little bit deviation. Yeah, and separately, MChat freely available. You have to just take a printout and attach into the,
Oh.
just ask the parents in a waiting room to just question and answer. Simple, and it's in their local language.
So, understanding it as a genetic part of a polygenic disorder, so do environment play a major role in the outcome of ASDs?
Yeah, because giving only therapy, so what does it contribute that there is a mother and father? Father goes to the work,
Yeah.
so mother has to do the household. How the story start with. So she has to complete her task. So she will think that let us put the screen. At least she will learn the rhymes, color, and this
Okay.
one. So from 10 minutes it goes to the feeding, and then it increases to the 1 hour, 2 hour. So as I said, there is a wiring,
Mm.
again firing the wires for the auditory and visual from the screen. That will make child more attached on a gadget rather than with the human being. If you see our childhood, our 70% time used to be with kids outside the home. And even you come to the home, there used to be a nuclear family. There used to be a complete joint family, and there used to be many
Yeah.
kids at the home, many adults. They used to interact. We never required even the TV. If you see one TV in complete
Mm.
that locality. Now every family has now every room one TV, but there are only two or three people in a home. So environment plays major role.
Mm. So, any consanguinity plays a role here, whether these are what kind
So
of inheritance pattern?
yeah, so as I said, Down syndrome. So if there is a
Mm.
late pregnancy, so the
Like,
like Down syndrome chances are more.
yeah.
Fragile eggs and many more autosomal recessive and disorders,
Yes,
because I don't go into details. It's very
yes. Yes.
list of
Yeah.
presynaptic, synaptic, and postsynaptic.
Okay.
But child with epilepsy, they may behave like there may be a regression in especially epileptic
Mhm. I request audience to put your questions in the Q&A chat. So sir is here to guide us on how to do the primary care if you're primary care physicians or pediatricians. So one more on the diagnosis part, sir, when do you advise a genetic testing in these parents or
See, when what
yeah.
strategy we use it being a clinician, if there is a obvious dysmorphic features like indicating Down syndrome, so we simply send a
Yeah.
karyotype, Edward targeted things. If we see that there is like no particular sign, then typical what we follow it is the whole exome sequencing. If obvious dysmorphism, chromosomal microarray, and then long testing. And clinically, if child is not at all responding to the medication, to the therapies, then reversely. But if you see the same strategy in a Western, on day one, they try to get all the genetic testing and then they go for that. But in India, there is a financial concern. So
Yeah.
we consider genetic as a last, metabolic and genetic. But one thing I want to insist that simple hypothyroidism may present like that.
Yeah. We have a couple of questions in the chat. Anshu Mishra is asking at what age one can start identifying symptoms of ASD and what can be the symptoms? I think overall sir has said, but yeah, I think.
If you see how early, in my experience, ideally it is the 18 months old that we usually by 18 months will be able to pick up the symptoms. But as early as 7 months to 9 months, I have seen there is no eye to eye contact, child not responding to sound. So obviously we have to do the hearing. But hearing was normal and still child is not giving eye to eye contact. So we need to suspect it early. But ideally it is 15 to 18 months they start noticing this. And this is the time where there is a vaccination time. Time it will be diagnosed. So there is a confusion, like MMR vaccination causes the autism, which is not true.
So Ruchika Sood is asking how to investigate. I think this was answered in a
Yeah, so there
what
is one more investigation role of EEG. As I said, there is a Lander-Kleffner syndrome or where there will be a centrotemporal discharges in EEG. So EEG is one of the diagnostic tool, and to rule out any structural abnormality, we need to go for the MRI in few cases, not in all. And obviously, metabolic and genetic testing is required. Simple vitamin B12, D3 deficiency, and hypothyroidism may be picked up early. That may be the reason for developmental delay also.
I believe there are no any prenatally is there a way we can find out apart from if there is a risk factor, is there a way that a child will develop?
See, if you go for the suppose one sibling is affected, so we go into if there is a nowadays as we know much science and even ideally also if first child is having autism, we try to do the trio analysis so that if we find anything into that, the antenatal testing will be very easy for the next child. So that anxiety of getting second child with autistic spectrum disorder or second trauma in their life will be more, and they try to avoid most of the parents' second pregnancy.
So what would be the challenges for early diagnosis? Because some would if how do you differentiate between late talkers or normal physiological delay or
See, the major
autism?
thing is acceptance by the parents. So if you say simple speech delay, child will be alert, active, responding to by the body language, eye to eye contact will be good. But there will be a selective speech. So there are late talkers, as you know. They say that even my father started talking late.
Yes.
So, but typically when you go through the criteria, you'll be obviously able to see that. And accepting that there is a delay. It is always the rejection reaction by the parent. If you disclose the diagnostic of autistic spectrum disorder, they will say it is not there. They will go to the 3, 4
Yes.
sequence for the diagnosis. They will change the centers. So that is the biggest challenge to convince the parent.
Yes.
The same parent, after a few days, they will accept and they will say, okay, now we are okay with the diagnosis. But disclosing physician or a therapist has to be very disclosing it with speech delay, social communication delay.
So what are the important factors that determine the outcome, long-term outcome of these disorders? Like unless they are associated with any other syndrome.
So if it is a non-genetic, obviously there will be a more possibility that they become normal. Then environmental factors. If the gene exposure is more and there are limited nuclear families, so that is again a virtual or acquired autistic spectrum disorder. So good factors are there. Any hypothyroidism or any medical condition, if you treat underlying that, they will improve. Any child with epilepsy and an autistic spectrum, if you treat the epilepsy, there will be improvement in that.
So there's one question in Q&A. Does in reading fuels will recessive neurological disorders and ASD kind of neurological disorders?
Yeah, so consanguineous marriage are already known to cause these things. So it is obviously mentioned in that, and it is a red flag that if there is a third degree consanguineous marriage, fourth degree consanguineous marriage, we alert and even in a first pregnancy itself will be taking help of the genetic counselor or genetic consultant.
So what would be the ideal age within which we need to treat these conditions?
Early development, as I said, 0 to 6 is the main thing, but 0 to 3 is the golden period, and after that, it is the we may get little bit late.
I think I've covered most of the questions from diagnosis to treatment, unless attendees have any other questions to ask.
I think we have answered almost all everything.
Yes. Thank you very much. Like Chaitana, can we, if
yeah, madam.
if no questions from the attendees, participants, I think thank you, sir, very much for your valuable time and enlightening us with the most important topic on ASDs and how early intervention of these disorders.
Thank you all.
Thank you.
Yeah. Thank you. Good day. Bye.